The school, which stands at the heart of the community, is a place where students gather every day to learn, grow, and build lasting friendships. While proceeding with the study of fetal anatomy, highlights during the transverse scan of the abdomen in the upper right abdominal quadrant. The presence of an oblong and anechoic formation attributable to the gallbladder, but accompanied more medially by a second, practically identical formation, also oblong and anechoic, not showing any color uptake. In fact, in these conditions, the application of color Doppler is fundamental, as it allows us to properly identify the umbilical vein, which is more to the left. And it is distinct from these two anechoic areas, which, as mentioned, do not show any color uptake and therefore are not vascularized. Furthermore, the use of color Doppler would also allow us to rule out cases of prubo, that is, a persistent right umbilical vein, since in this case the umbilical vein, upon entering the abdomen, would tend to move more laterally to the right in relation to the gallbladder, then curving toward the stomach. In that case, the gallbladder would appear as a single anechoic structure positioned more medially. Duplication of the gallbladder is a rare congenital anomaly with an incidence of 1 in 4,000 live births. It is more prevalent in females. It is characterized by a defect in the biological development of the biliary system between the 5th and 6th week of gestation. Several theories exist regarding its etiopathogenesis. The most widely accepted is the primary cystic bud theory, an invagination of the hepatic diverticulum that tends to bifurcate. Less accepted is the persistence of accessory buds theory, which are produced in large numbers between the 5th and 6th week. Thank you. But those supernumerary ones then regress. When this does not occur, their persistence can be responsible for the development of a duplicated gallbladder, as also happens in the case of double primordia, that is, from the common biliary duct. Two formations arise, two cystic primordia, from which two gallbladder structures will then develop. The process, as we have seen in prenatal ultrasound, is carried out with a transverse scan of the fetal abdomen. In the upper right abdominal quadrant, in fact, two anechoic, elongated and adjacent formations are visible, located contralaterally to the gastric bubble. As we mentioned, the use of color Doppler is essential because it allows us to distinguish the umbilical vein, which appears more to the left and is vascularized, thus showing up on color Doppler, from the gallbladder. In this case, the double gallbladder structure is located more to the right and does not show up on color Doppler, meaning it is not vascularized. To date, there is no clear correlation except in extremely rare cases with structural anomalies or chromosomal aberrations. Sometimes, and again only in extremely rare cases, the condition can be associated with cases of duodenal atresia, or with other anomalies of the gastrointestinal tract. Gallbladder duplication is currently classified based on the stage during embryogenesis in which the separation occurs. This is referred to as the Boyden classification. Among these, the most common form is the so-called Y-shaped type, which is a septate or bilobed gallbladder, where there is a septum, an invagination along the longitudinal axis, that completely divides the lumen into two chambers, but with a single cystic duct. Less common is the double gallbladder, or true duplication, in which there are two separate gallbladders with two separate cystic ducts, thus forming an H shape, which are then connected to the main biliary tract. Even rarer, in fact extremely rare, is a form known as mixed or hybrid, in which there are actually 3 gallbladders but only 2 cystic ducts, since they are connected to the main biliary tract by a single duct for one gallbladder, and then another duct for a gallbladder that appears bilobed. The identification of this second onechogenic formation requires differential diagnosis with other cyst-like formations affecting the fetal abdomen. The position and ultrasound characteristics allow us to rule out certain conditions, in particular the coldocal cyst, which appears as a rounded formation near the liver, specifically along the intrahepatic portal segment of the umbilical vein. This pathology is usually associated with other anomalies of the gastrointestinal tract, among which in particular is biliary atresia, where the gallbladder is typically not visible or is noticeably smaller. Also to be considered in the differential diagnosis are cases of mesenteric cysts, which usually appear more medially and more frequently affect the lower abdominal quadrants, as well as enteric duplication cysts, which present with a rounded or tubular appearance and communicate with a small segment of the intestine. Therefore, with prolonged observation, it is often possible to see their peristalsis as well. All these cystic formations are usually easily distinguishable from those we see in these scans, since none of them display this appearance, which is typically adjacent and parallel to the gallbladder. Other conditions that need to be considered in the differential diagnosis include gallbladder diverticula, cases of PRUV as we saw at the beginning of the video, and also hepatic cysts, which usually appear in the upper right abdominal quadrant, affecting the hepatic parenchyma, particularly the anterior lobe, with a typically rounded appearance. And it is usually not adjacent to the gallbladder. There are also cases of cystic abdominal lymphangioma, which is a lesion that affects the lower abdominal regions. It presents a characteristic echostructure, usually large with a multicystic, multiseptated appearance, resulting in a more heterogeneous echostructure, very different from a classic cyst and typical gallbladder duplication. Continuing with the detailed study of fetal anatomy, in our specific case, a mild bilateral dilation of the renal pelvis was observed, 6 mm on one side, 7 on the other. The remaining part of the anatomy studied appears normal. The fetal biometry corresponds to the regular gestational age, the fetal head, the raised cavity, is clear, visualized, and the insula as well. The posterior cranial fossa also appears normal and the amniotic fluid is regular. In the clinical case under examination, the patient presents with mild obesity, resulting in reduced echogenicity of the maternal tissues, which made the use of cardiac anatomy difficult, but not impossible. In fact, we can see the right section, the V sign, and thus the 3-vessel trachea view. Next, the 4-chamber view, the long axis scan of the left side, and the 3 vessels, resulting in an adequate and proper evaluation of the cardiac anatomy, which appears perfectly normal. Therefore, duplication of the gallbladder is a benign finding, usually isolated. Thank you. And with a diagnosis that, in most cases, occurs incidentally in adulthood. In prenatal management, it is possible to reassure the patient by performing a detailed and accurate obstetric ultrasound of the fetal anatomy, an assessment that will allow us to rule out any association with other structural anomalies. Invasive testing and genetic counseling are indicated exclusively in cases where this association is identified with anomalies of the gastrointestinal tract, such as, for example, duodenal atresia or possibly cardiac anomalies, and then, after birth, an ultrasound check will be performed to confirm the suspected diagnosis. Thank you. The suspected condition. Thank you for your attention.